Audible and visible? Please give me a quick thumbs up, all my dear students. I hope I'm audible and visible. Dr. Chip, Yogesh, am I audible and visible? I hope you can hear me. Very nice. Welcome to the next session of chapter-wise discussion in dermatology. And today we will be discussing a very, very important topic, and that is appendageal disorders. Yesterday we had discussed about the basics, few questions, and there were different aspect of the basics. For example, the basic of skin, basic of the different lesions of the skin. So these were the topics which we have touched upon yesterday. And today we will be doing the questions from the appendageal disorders like hair, sweat glands, etc. So I hope these sessions would be very beneficial for all of you, and this will help you understand that among dermatology, which topic is strong for you and which is which needs a lot of time for you to spend on. So let's discuss and welcome all my dear students, Meghna, Tulika, then we have Bindu, Sachi, Pradeep, Nimisha, then Srijit, Lost, Gotham, Fight, all my dear students, welcome in this session. Till the others join, let's just go a very quick through the new batch courses. So I'm Dr. Chesta Agarwal, your NEET PG educator, and you all are on the best online platform for the preparation of NEET PG, that is Unacademy. We give two types of subscriptions. One is Plus and another is Iconic. Plus give you an access to the live classes of Unacademy from the top educators of the country. You can access it with any device. We have availability of the printed notes. Very soon you'll get to have these printed notes with you. And then we have Iconic subscriptions. We have Iconic subscriptions where you have an access to Unacademy along with that of Prep Ladder. Now, there are many batch courses which is getting started. For example, we have a Focus FMG batch course starting on 4th, Target Next again starting on 4th, and we have two batches which is absolutely dedicated to your upcoming NEET PG. That is TND batch and an ultra fast track revision batch course. Now, both these batch courses will have multiple tests, daily tests with its analysis on the same day, around 12 grand tests. And this is the list of the grand tests you will be expecting up till your NEET PG entrance examination. So I would recommend all my dear students to please subscribe or take a 2-month subscription of Unacademy using a referral code CHESTA10. 2-month subscription would be of 6750. You can access all the courses on Unacademy, those who have already occurred, so you can see the recorded session and you can avail all the live courses. So it is unlimited access to the platform by this window of 2 months. Using a referral code CHESTA10, you can get the same in 6,750 rupees. So I request all my dear students to please go ahead and buy it. We also provide 4-year subscriptions of 60,000 rupees for Plus and 75,000 rupees for Iconic. Currently, the Iconic prices has been revised, and on 5th of August, we are expecting the raise. So you have 2 more days left. Please remember, on 5th August, the prices of Iconic is increasing. The prices of Iconic is increasing, which means that these prices may go back to these prices. So if at all you are planning for a longer subscription, go ahead and get Iconic today. 5th August would be the last date. Now, this is the price list. Whatever subscription you want to take, 2 months would be best for NEET PG, 3 months for FMG, and 1 year of either Plus or Iconic would be best for next pattern examination. And please use my referral code CHESTA10 for further 10% discount. So notification nahi aaya. I think I also not got any notification, but anyways, I've told you that every day 2 p.m. the class timing is fixed, and morning also most probably 11 a.m. only, because we could not come to any conclusion in the morning session for the timing. So for time being, I am keeping it at 11 a.m. only, and this is 2 p.m. for at least this month. So at least for this month, there should be no confusion. On Sundays, remember, there will be no class or at 2 p.m. on Sundays. So that is just a brief to all of you. Yes, this is an MCQ based session. We are doing it chapter wise. All those who are attending the class today for the first time, this is the second session. Yesterday we have discussed the questions on basics. Today we have questions on appendageal disorders. So all of you give me a quick thumbs up if you are ready for the first question of the today's session. All my dear students, give me a quick thumbs up if you are ready for the first question. Amazing. Your first question is here with image Please tell me the answer. 30 seconds on your computer screen. Very nice. Amazing, all my dear students. Very nice. Sunny, Dr. Ajay, then we have Pavitra, Pankaj, Ruhi, Nirupam, LAV, CD, all my dear students. Amazing. This is the first question for all those students who are joining right now. Please answer this question. This is the first question of the today's session. We have 72% of the total students have answered this question. Amazing. This is a classical example of isotretinoin induced cleft lip or cleft palate or the developmental anomaly. Now, please remember, isotretinoin is considered to be the drug of choice for grade 4 acne. And common age for developing acne is the young age, that is the adolescent period, or when a female is fertile. Now, please remember, you never give isotretinoin in a patient who is planning for pregnancy. Can anybody tell me how many days gap should be present or how many drug-free intervals should be advised to a patient if she's planning for fertility or pregnancy, or if she's planning for pregnancy? Very nice. Remember, on giving isotretinoin, the female should be asked to stop it at least 1 to 3 months before getting pregnant. So there should be a 1 to 3 month interval after stopping the drug and before getting pregnant. Otherwise, the patient can suffer with a lot of side effects. One of them is teratogenicity, which can give rise to the side effects like cleft lip and cleft palate. Clear, all of you? So this is with respect to isotretinoin. Can you tell me what should be the drug-free period when you give acitretin in a patient of psoriasis? Anyone? So for acitretin, which is also an oral retinoid, both are oral retinoid, but the difference is acitretin is a lipid-soluble drug. It's a lipid-soluble drug, so it requires around 3 years. And that is why it is our protocol that do not give acitretin in a reproductive age female for treatment of psoriasis, because you need a 3-year strict contraception after stopping the drug. While isotretinoin, which is a water-soluble drug, it requires only a 1 to 3 month drug-free interval before getting pregnant. Clear, all of you? Please give me a thumbs up if this point is clear. Very, very important question for your exam. Very, very important question. Which of the following medication taken during pregnancy is responsible for the defect seen in this patient? This is isotretinoin. Now, can you tell me which is the most common side effect of isotretinoin? Which is the most common side effect? I request all of you to tell me very quickly. The most common side effect is dryness of lip or cheilitis. Very, very common side effect, dryness of lip and cheilitis. Other side effect is it causes abnormality in the liver function test. It increases the triglyceride level, and that is why we need to do a baseline lipid profile and liver function test. Okay? Another is it causes pseudotumor cerebri, and that is why we never combine isotretinoin with doxycycline. Okay, ji? Third is a very rare side effect. What is that? What is the rare side effect? It is DISH, which is diffuse idiopathic skeleton hyperostosis, DISH, diffuse idiopathic skeleton hyperostosis. Clear, all of you? So these are some of the side effects along with teratogenicity. So always plan isotretinoin with caution. Now, can you tell me what should be the cumulative days? What should be the cumulative dose for giving isotretinoin? That beyond that, the risk of side effects increases. Meghna, it is a very incomplete answer. What 150 means what? Please write it down as a whole. 150 mg or what? So please remember the cumulative dose is 120 to 150 mg per kg body weight. It is not only 120 to 150 mg, because if it is 120 to 150 mg, we usually give 10 to 20 mg per day. So only 10 days. No, that is not true. So it is 120 to 150 mg per kg of cumulative dose, beyond which the risk of side effects increases. Clear, all of you? So we have discussed almost everything which can be asked with respect to this particular question. I hope it is clear to all of you. Should we start the next question? And whatever I have told you, it is written here. The most common is dryness. You have abnormal LFT, diffuse idiopathic skeleton hyperostosis, pseudotumor cerebri, and teratogenicity. So no need of worry. Everything is given in this PDF. You can just download it after your class. Should I go to the next question? Everyone ready? Amazing. Very nice. Shravani, Vinisha, Taiba, Shetaz, Himanshi, Fatima, Ankita, Dr. Grace, Jaya, Nadi, Rohit. Please tell me the correct answer of this question, all my dear students. Oh, very nice, all my dear students. We have 35% of the total who have answered this question correctly. Now, there's a very common myth that when you start seeing the patients, the mother will accompany the patient and he will say or she will say that, ma'am, my daughter or son is taking a lot of oil and that is why he or she is developing a lot of acne. Please remember that is not the correct thing. The oily food will never increase the acne, but instead the food which cause increase in insulin like growth factor 1, for example, milk and milk products, as well as the food with high glycemic index. And can you name one high glycemic index food which is, I think, the universal favorite of all of you? High glycemic index food which is a universal favorite. Banana, so it's a good thing. The universal favorite high glycemic index food is chocolate. How many of you love chocolate? Yes. So please remember, if you get a patient, advise him or her not to consume these agents or these food, because all these foods will cause increase in insulin like growth factor. And what does insulin like growth factor do? Insulin like growth factor will go and stimulate the sebaceous gland for production of more and more sebum. So when there is more and more sebum which is associated with obstruction of the follicular outflow, you will have increase in the skin lesions, you will have more nodules, more cyst. Understood, all of you? So now you know how or what to prescribe. Please remember the correct answer is option number 1. This is interleukin 1 has a pro-acne effect. Please remember, among the all 4 options, the correct answer is option number 1, not option number 4. Interleukin 1, see, inflammation play a role, but which is the pro-acne? Inflammation occurs once the acne sets in. But the pro-acne effect is with IGF-1, which causes increase in the sebum production. And when the sebum production increase, obviously there will be more and more accumulation, giving rise to the involvement. Okay, ji? I hope that is clear to all my dear students. Chalo ji, fine. Should I go to the next question? Pradeep, it is not necessary that all the patients with the lactose intolerance will have associated acne form eruptions. That is not true, because as such lactose do not cause any increase in the sebum production, but yes, it can cause increase in the IGF-1. But definitely the best possible answer among the option would be option number 1. Is that clear to all of you, Pradeep? Yes or no? And I hope I was able to correct everybody's answer. Does growth factor indirectly increase acne? Yes, it can cause. Definitely it can cause, because all these growth hormones, they will cause sebum production. So there is an indirect way from which it can increase the acne formation. There are a lot of factors, and that is why we consider acne to be a multifactorial condition. Clear, all of you? Should I go to the next question? Anyone has any confusion? Okay, good, badhiya. The next question: what is Cox peculiar tumor? What is Cox peculiar tumor? Very nice, Tashneem, Sonali. Amazing, all of you. Shetaj, Scarlett. And I can see that only few fraction of students are able to answer the question all the time. I request all of you to please start preparing the short subjects also. They are very important. Do not take it granted, especially the short subjects. Very nice. The Cox peculiar tumor, the correct answer of this question is option number 1. The Cox peculiar tumor, please remember, the correct answer is option number 1, that is infected sebaceous cyst. Now, if you remember, a few days back, I've asked you a lot of questions with respect to infectious sebaceous cyst. Now, first of all, you have to tell me what is the content of a sebaceous cyst. All of you, what is the content of the sebaceous cyst? Frequently asked question. So, Dr. Baby is again trapped on the confusion. Please remember, the content of the sebaceous cyst is keratin. The content of the sebaceous cyst is keratin, and remember that it is a misnomer. It means that we have given this name falsely. What should be the correct name? It should be known as epidermoid cyst. So please remember, the content of the sebaceous cyst is not sebum. It has nothing to do with the sebaceous gland. Remember, it has nothing to do with the sebaceous gland. You have the inoculation of the skin, and secondary to that, there is release of lot of keratin forming a cavity, and that is called as epidermoid cyst. And sometimes they get infected to form large lesions like this. They can have ulcerations, they can have pus, sinuses, etc. So this is how an infected sebaceous cyst look like, or a Cox spicular tumor look like. Nothing to do with the sebaceous gland. Understood, all of you? So please don't get confused. It's a misnomer, and I've taken a class on misnomers. I hope you have attended those sessions. Chalo ji. Next question. All of the following are non-cicatricial type of alopecia, except. Time starts now. Very nice. Amazing, all of you, amazing. Very well done. So we have a lot of students, and I'm getting good answers from all of you. But still, among 200 students, only or less than 50% are answering all the questions. So you can assess yourself that still you need a lot of preparation. All of the following are non-cicatricial alopecia, except. First of all, what is alopecia? Alopecia means hair loss, which is of two types. One is non-cicatricial, and another is cicatricial. Can you tell me what you mean by cicatricial? What do you mean by cicatricial? Cicatricial means scarring, and non-cicatricial means non-scarring. So they are asking you the question, or they are asking you, which among the following is a cause of scarring alopecia? Alopecia areata, ectodermal dysplasias, and androgenic alopecia, all these three are example of non-scarring, while pseudopallid of Brooke is an example of scarring alopecia. And can you tell me a very characteristic appearance which you see clinically? Very nice, Roche Shipra. It is footprint in snow appearance. Footprint in snow appearance. So that patchy loss of hair will give you an appearance as if there are footprints on the snow. Very nice, all of you. Now, how to differentiate scarring alopecia from non-scarring alopecia clinically? Anybody can tell me how we differentiate scarring from non-scarring? Can you tell me the answer? So please look at this image, all my dear students. In non-scarring alopecia, you will see presence of empty hair follicle. Can you see these black dots? These are the empty hair follicle, very classical of non-scarring alopecia. Clear, all of you? I want a thumbs up from all my dear students if you can appreciate this. Very nice, amazing. And what about the scarring alopecia? Please remember, in scarring alopecia, you will see presence of scars, or you will see presence of wrinkling without empty follicles, or without any hair follicle, without empty hair follicle. Please give me a thumbs up if you can differentiate this image from the previous image. You can clearly see that there is presence of, wrinkles over this, and that is why you need to differentiate both of them clinically. Okay, ji? I hope this is clear. Now, somebody have asked me that, ma'am, what is ectodermal dysplasia? Now, ectodermal dysplasia means a group of disorders or those diseases where you have deficiency or defect of ectodermally derived tissues. For example, whenever you have defect of skin, hair, nail, teeth, as well as sweat glands, which are the ectodermally derived tissue, please remember that is termed as ectodermal dysplasia. In ectodermal dysplasia, you will see loss of hair, but that is not scarring type because there is no inflammation taking place here. You have congenital abnormality in the ectodermally derived tissue, and that is why it is considered to be, a non-scarring type of alopecia. Clear? Please give me a thumbs up, all my dear students. Yes, this is a chapter-wise class, Roshit. If you are a beginner, I would recommend you to attend a plus course. Otherwise, it becomes very difficult for you to follow these classes. This includes the MCQ-based sessions so that you can revise the topic subject-wise. I've also started a plus course, and that is why I recommend all of you to take a 2-month subscription using a referral code Chesta10 so that you can prepare the plus along with the special class. Okay, ji? I hope this is clear to all my dear students. Okay, ji? Let's move to the next question. Shipra, ectodermally derived tissues are defective in ectodermal dysplasia, like hair, nail. I hope I'm visible because the lights are gone at my end. I hope I'm visible to all of you. Chalo ji, fine. Let's start the next question. Should I go for the next question, all of you? Amazing. Chalo. Please tell me the correct answer for this question. Please mark the question over the chat section, Ashley. Nobody will mark the question over the chat. Please mark the question over the poll option, because if you will write the answer over the chat section, obviously the students will get biased. So please do not write it over the chat section until I ask you to do so. Okay, ji? Fine. So the correct answer here is option number 2. You all are right who have marked this. Now you can see in the image, look at the image. You can see presence of nodule and cyst. Now please remember, in grade 4 acne, you have nodule and cyst. And you also have 2 variants of acne which presents with nodule and cyst. One is acne conglobata. And another is acne fulminans. In both these type of acne, you will see presence of nodulocystic acne. But my question is, what is the difference between both? In acne conglobata, you will have no associated constitutional symptom. No constitutional symptom. And the treatment of choice is isotretinoin. But for acne fulminans, you have associated constitutional symptoms. And the treatment of choice is steroids. Now, let's read the question. Now, option number 1 says that it is usually associated with flushing and intolerance. Can you tell me, where do you see flushing and intolerance to heat and spicy food? Anyone? Yes, this is a feature of rosacea. So this becomes a wrong statement. Now, option number 3, oral antibiotic and oral retinoid is a treatment of choice. Please remember, neither in acne conglobata, neither in acne fulminans, the treatment of choice is not antibiotics or topical retinoid. The answer should be oral retinoids, but that is not given in the option. And option number 4 is again wrong because it needs oral retinoid, not oral antibiotic. And that is why the best possible answer becomes option number 2. Clear, all of you? Yogita, please give me a thumbs up. All my dear students, Sana, Dr. Richpal, Baby, Aruba, clear? Fine. So this is a classical example of acne conglobata, which presents with nodulocystic lesions over the trunk followed by face. Okay. Why some dermatologists give doxycycline? Okay. So Dr. Arush, you can combine the antibiotic with oral retinoids. Now, when you have more of a pustular lesions, doxycycline becomes a better option compared to oral retinoid. But if you're having more of nodular lesion, the retinoid becomes the treatment of choice. Clear? Very nice, all of you. So identify the following lesions: Baker's nevus, hypopigmented macule, Spitz nevus, or epidermal nevus. Identify the following lesions. Very nice, amazing. I think it is one of the very easy image-based question you can get. Classical example of a Baker's nevus. Baker's nevus is an hyperpigmented epidermal melanocytic collections or nevus which presents mainly over the trunk. The nevus cell, it consists of the androgen receptors, and that is why they tend to become very large in size at the time of adolescence. And you have associated hypertrichosis and acneiform eruption. Now, I have an image here for the Spitz nevus, which is very important for you to remember. Spitz nevus is a melanocytic nevi which was initially confused with malignant melanoma because of histopathological resemblance. But later on, it was considered to be a completely benign condition, common in children, and there was absence of any atypical nature of the melanocytes. The classical feature is there is presence of a specialized camino bodies on histopathology. So please remember this image. You can get a question because I think very recently in the AIMS exam, you had the question on Spitz nevus, and that is why I thought of putting an image for all of you. So please remember, this is a very important question. Let's go to the next question. All of you ready for the next question? Very nice, Yogesh, Ashu, INICT, Dr. Sonali. Then we have Himanshi, Aruba. Very well done, very well done. Nevus pilus is different, Sharat. Nevus pilus is a completely different entity. Nevus pilus is also called as speckled pigmented nevus. So what is happening there in speckled pigmentation? You have hyper and hyperpigmented lesions which are distributed in a salt and pepper appearance. But that is completely different from Spitz nevus. Different, okay? Understood what is Nevus pilus, Sharat? Completely different entities. I don't have any image for the Nevus pilus right now. Otherwise, if you will compare it, they are totally different. Now, this is a question from the prognostic marker of which disease? Anyone? Can you tell me what is the diagnosis here? Yes, alopecia areata. And please remember, all of the above are the marker of alopecia areata or the poor prognostic factors of alopecia areata. Can anybody tell me few more poor prognostic factors other than this? Few more poor prognostic factor other than this? Can you ask? Can you tell me? One is early onset. Second is associated atopy. Third is widespread alopecia. Anyone with any other? Yes, very nice. When you have other associated autoimmune conditions, Second is when you have other associated nail features like presence of geographic. What is that on the nail? Yes, geographic pit, very important. So these are some of the associated poor prognostic marker. The early onset, the widespread lesions, associated history of atopy, autoimmune disease, and presence of nail features all together are the poor prognostic factors of alopecia areata. Okay, this is very important. You can get a lot of questions out of it, and that is why I thought of putting it together. And now we have one more question. Very quickly answer this one. I think you don't need 30 seconds for this. 15 seconds for your very short question. Name the solid lesion of more than 0.5 centimeter. So this question should come yesterday actually. We have already covered the different type of lesions. Remember, in my plus course, I discussed all these lesions very in detail. What are the macule, papule, pustules? What are primary skin lesions, secondary skin lesions? So I request all my dear students who have never attended, please try to attend at least once the plus course. We will be taking the plus course for this month. We have 20 hours of whole dermatology for this month. So please try to be with that. Now, please remember why this is not a plaque. Why we have considered nodule as the answer, because please remember, solid lesion of more than 0.5 centimeter, it is always a nodule. Solid lesion of more than 0.5 centimeter is always a nodule. Plaque is alteration in the consistency. Alteration in the consistency, which can be either raised or can be depressed. And looking at this image, it's a classical example of a nodule. How to differentiate? Papule has a only superficial consistency, while nodule looks very small at the top, but when you feel it, it has a deeper component attached to it. So nodule is somewhat like this. Clear all of you? So this is a classical example of a nodule, which is a solid region of more than 0.5 or 1 centimeter. Most frequently, it is more than 2 centimeters when you take the whole depth. I hope this question is clear to all of you. Please give me a quick thumbs up. And with this, we are done with the today's session of the appendageal disorders. It is a very brief session. I request all my dear students to please take a 2-month subscription with a referral code Chesta10 and subscribe to Unacademy. So bye bye all of you. Take care and good day. We'll meet again tomorrow at 11 a.m. and at 2 p.m. with another interesting sessions like that. Till then, take care and bye bye.